Today's topic is hepatitis B virus, and also we discuss about the hepatitis D, that is a delta virus. Hepatitis B virus having a core containing DNA and a DNA polymerase enzyme which is needed for the virus replication. If we see over the right side at the center, there is a hepatitis B virus polymerase and it is enclosed by the hepatitis B virus DNA. Core of the virus is surrounded by a surface protein, hepatitis B surface antigen, which is shown in rounded balls, bluish in color. Humans are the only source of infection. Most common cause of chronic liver disease and hepatocellular carcinoma. Approximately 1/3 of world's population have serological evidence of past or current infection with hepatitis B. Approximately 350 to 400 million people are chronic hepatitis B surface antigen carriers and cause acute viral hepatitis and also chronic hepatitis B, also asymptomatic. If we see in this slide the prevalence of the hepatitis B virus, the bluish show the 8% or the more higher, and it shows over the China and the Africa and South America and Canada. While intermediate 2 to 7%, it is seen in the subcontinent, in the Middle East, and also in the South and the North America, along with the Russia. And less than 2% is shown by the white. So it is all over the world. Hepatitis B virus, it is related to the group Hepatena virus and nucleic acid DNA. Size is 42 nanometer. Incubation period is 4 to 20 weeks. And it is not separated by the fecal oral but by the blood, saliva, vertical and sexual. Chronic infection, yes, it is present, and prevention by active vaccination and passive by the hyperimmune serum globally. Serological and biological marker of the hepatitis B infection, if we see, it is hepatitis B surface antigen, anti-hepatitis B surface antibodies, anti-hepatitis B core, IgG and IgM antibodies, hepatitis B antigen and anti-hepatitis B antibodies. While the hepatitis B virus DNA by ELISA, we can do the qualitative and quantitative in the blood usually. Hepatitis B surface antigen shows active infection. It appears late in incubation period but before the prodromal phase of the acute hepatitis. It persists for few days only but usually lasts for 3 to 4 weeks and can persist for up to 5 months. Persistence of hepatitis B surface antigen more than 6 months indicate chronic infection. Antibody to hepatitis B surface antigen usually appears about 3 to 6 months and persists for many years or remain permanently. It shows previous infection if the anti-hepatitis B core antibodies is present, and it shows previous infection where the anti-hepatitis B core antibodies is absent. Hepatitis B core antigen not found in the blood, but antibody to anti-hepatitis B core antibodies appear early in illness and rapidly reaches a higher titer, which subsides gradually but then persists. Initially, IgM type with IgG antibody appears later. Hepatitis B antigen indicator of active viral replication in liver. In acute hepatitis, it appears only transiently at the outset of the illness. Its appearance is followed by the production of antibody. If we see in this graph, the yellow shows the hepatitis B antigen, which shows the active replication. It appears before the clinical illness appears, and then goes before the 3 months. While hepatitis B surface antigen, it goes up and goes within 5 months because it shows the acute viral hepatitis. Anti-B antibodies appear after 2 months and persist, and anti-hepatitis B surface antigen after 6 months and remains there, and anti-hepatitis B core antibodies IgG and IgM shown in this slide. Viral load and genotype can be measured. Hepatitis B virus DNA can be measured by the PCR in the blood. Viral load usually in excess of 105 copies per ml in the presence of active viral replication. With low viral replication, viral loads are less than 105 copies per ml. Measurement of viral load is important in monitoring the antiviral therapy. Specific hepatitis B virus genotype A to H can also be identified using PCR. Genotype is useful in guiding therapy. That is, genotype A tends to respond better to pegylated interferon alpha as compared to the genotype C and D. Disease form hepatitis shows acute hepatitis B or chronic hepatitis B. Acute hepatitis B, caused by hepatitis B virus, which develop within 6 months after entering into the individual. Disease has symptoms or asymptomatic course. In more than 90% of the cases, it is self-limited disease. Clinical features: mostly the infection is subclinical. When acquired perinatally, acute hepatitis usually does not occur as there is a high level of immunological tolerance and virus persists in over 90%. If there is an acute clinical episode, virus is cleared in approximately 99% of the patient and there is a good immune reaction. Clinical picture same as in hepatitis A virus infection, although the illness may be more severe. Extrahepatic immune complex mediated conditions such as arthritis or glomerulonephritis are occasionally seen. Clinical features non-specific are the headache, malaria, arthralgia, nausea, and anorexia. Usually precede the development of jaundice by a few days to 2 weeks. Dark urine and pale stools may precede the jaundice. Icteric phase, vomiting and diarrhea may follow, and abdominal discomfort is common. Itching may be present and it shows a cholestatic picture. Liver is often tender but minimally enlarged. Occasionally, mild splenomegaly in 10 to 20% of the cases are seen. Recovery phase, constitutional symptoms disappear, but some liver enlargement and abnormalities in the liver biochemical test are still evident. Duration of the post-icteric phase ranges from 2 to 12 weeks or maybe longer. Complete clinical and biochemical recovery is to be expected 3 to 4 months after jaundice appear in self-limiting disease. On the picture you see the sclera, which is yellowish in color, and below the patient is itching over the forearm. Investigation in acute hepatitis B virus: serum transamylase, ALT and AST typically between 200 to 2000 in acute infection. Plasma bilirubin shows the degree of liver damage. Alkaline phosphatase rarely exceeds twice the upper limit. Prolongation of the PT indicates the severity of the hepatitis. WBC is usually normal and with relative lymphocytosis. Serological test confirms the etiology of the infection. As we already see this slide, this shows a serological and virological marker of the hepatitis B virus. If we see in acute hepatitis B virus, the hepatitis B surface antigen is positive in acute hepatitis B virus infection. Hepatitis B antigen is also positive, which shows the active replication. Anti-hepatitis B core antibodies total and IgM is positive in acute infection. Hepatitis B virus DNA, when PCR was done, it is also positive. On the graph, you can see during the hepatitis B virus DNA, hepatitis B antigen, and hepatitis B surface antigen are present, shown by the pink, green, and blue color shades. Interpretation, if you see in acute hepatitis B virus serological, the incubation period, during incubation period, the hepatitis B surface antigen and anti-hepatitis B core antibodies of IgM type is present, and it is also present during the early stage of the acute hepatitis. In established case, then the anti-hepatitis B core antibodies of IgG type may appear. In convalescence, during 3 to 6 months, the hepatitis B surface antigen disappear and anti-B core antibodies of IgM type is present during 3 to 6 months, may be present or may be absent, but anti-hepatitis B core antigen of the IgG type was present, and in 6 to 3 months it is also present with anti-HBs antibodies. Post-infection shows by the anti-hepatitis B core antigen. Immunization without infection only shows the anti-HBs, in which the anti-HB core antibodies are absent. Management of acute hepatitis B is supportive with monitoring for acute liver failure, occurs in less than 1% of the cases. No evidence that antiviral therapy reduces severity or duration of acute hepatitis B. In adults, full recovery occurs in 90 to 95% and occurs within 6 months. 5 to 10% develop chronic hepatitis B infection. Infecting passing from mother to child at birth lead to the chronic infection in child in 90% of the cases, and recovery is rare. Chronic infection is also common in immunodeficient individuals like Down syndrome and HIV infection. Combined hepatitis B virus and hepatitis D virus infection causes more aggressive disease. Chronic hepatitis B. Hepatitis B infection and risk to chronic infection depends upon the source and timing of the infection and vertical transmission from mother to children in the perinatal period, as shown below in the chart. Horizontal transmission is injecting drug users, infected, unscreened blood products, tattoos, acupuncture needles, sexual transmission, and close living quarters. Vertical transmission is from mother to the child. Natural history of the chronic hepatitis B virus infection shows an immunotolerant phase where the high level of virus and normal level biochemistry, as shown over the right side upper graph with yellowish discoloration. With immunological response to virus occur with elevation in serum transaminases, which causes liver damage, chronic hepatitis, as shown in the lower graph. If this response is sustained over years, then viral clearance does not occur properly, and chronic hepatitis may lead to cirrhosis. Individuals with successful immunological response, viral load falls, and hepatitis B antibodies develop with no further liver damage. Some persons subsequently develop hepatitis B virus DNA mutants that escape from immune regulation, and viral load again rises with further chronic hepatitis. Mutation in core protein results in virus inability to secrete hepatitis B antigen despite high level of viral replication, such as individuals called hepatitis B antigen negative chronic hepatitis. Below in the liver histology, we see normal, then chronic hepatitis, minimal inflammation, the chronic inflammation, and then cirrhosis and leading to the hepatocellular carcinoma. This shows the healthy liver, the chronic hepatitis leading to the cirrhosis and hepatocellular carcinoma. This is the graph which shows the 5 phases which we already discussed. Laboratory markers of the chronic hepatitis B virus. It is marked by the presence of the hepatitis B surface antigen and anti-hepatitis B core antibodies of IgG in the blood. And hepatitis B antigen indicates continued active replication. Absence of hepatitis B antigen usually implies low viral replication. So if we see below, hepatitis B surface antigen positive, hepatitis B antigen positive, anti-HBC total and IgM positive, and in case of IgM that is positive or maybe negative, and hepatitis B virus DNA is positive. Management of chronic hepatitis. The goal is hepatitis B antigen seroconversion, reduction in hepatitis B virus DNA, and normalization of the LFTs. Indication for treatment: a high viral load in the presence of active hepatitis. Drugs: oral antiviral agents are more effective in reducing viral load in patients with E antigen negative chronic hepatitis B than with E antigen positive chronic hepatitis. Two different types of drugs are used: direct acting nucleoside or nucleotide analogs and pegylated interferon alpha. Direct acting nucleoside or nucleotide antiviral agents are the mainstay of therapy, orally administered and acting by inhibiting the reverse transcription of the pre-genomic RNA to hepatitis B virus DNA by hepatitis B virus DNA polymerase. Lamivudine 100 milligram effective, but long-term therapy caused hepatitis B virus DNA polymerase mutant and leading to viral resistance. So it is seldom used. Entecavir 1 milligram and tenofovir 300 milligram orally per day is substantially more effective than lamivudine in reducing the viral load in hepatitis B antigen positive and B antigen negative chronic hepatitis. Antiviral resistance is only 1 to 2% after 3 years of the entecavir drug exposure. Interferon alpha most effective in patients with low viral load and serum transaminase greater than twice the upper limit. It is given in 180 microgram once weekly subcutaneously, and response rate is 25 to 45% after 48 weeks of treatment in genotype A and B. Side effects: having acute flu-like illness, malaise, headache and myalgia, depression, reversible hair loss and bone marrow depression. Liver transplantation contraindicated to hepatitis B because infection often recur in the graft. Use of post-liver transplant prophylaxis with direct-acting antiviral agents and hepatitis B immunoglobulin reduces the reinfection rate to 10% and increase 5-year survival to 80%. Prevention and prophylaxis: not sharing needles and having sex safe. Vertical transmission should be avoided. Infectivity is highest in those with E antigen and or hepatitis B virus DNA in their blood. Blood and blood products should be screened. Accidental needle puncture and contact with infected body fluid in laboratory and in hospital should be strictly followed. Active and passive immunization can be given in the group with high risk, all healthcare personnel and persons of emergency, mortician and the embalmers, children in high risk area and hemophilic patients, patient with chronic kidney disease on dialysis unit, long-term travelers, men having sex with men and intravenous drug users. Combined prophylaxis: vaccination and immunoglobulin starved with accidental needle stick injury, all newborns with hepatitis B surface antigen positive mothers and regular sexual partners of the hepatitis B surface antigen positive patients. Dosage is 500 international units of specific hepatitis B immunoglobulin is given and the vaccine is given at another site intramuscular. Active and passive immunization: dosage is 3 injections, 0, 1 and 6 months are given in the deltoid muscle. It gives short-term protection in over 90% of the cases, and booster dose may be required after approximately 3 to 5 years. Prognosis: very variable, and treatment have improved survival and stop progression of fibrosis and enable regression of the fibrosis to occur. Progression from the acute to chronic phase depends on the age at which infection is acquired. Established cirrhosis is associated with poor prognosis. Hepatocellular carcinoma is a frequent association. Incidence of hepatocellular carcinoma is being reduced by routine hepatitis B virus vaccination in all children. Co-infection with HIV around 10% increases the morbidity and mortality, faster progression to chronic infection and greater risk of cirrhosis and hepatocellular carcinoma. Pregnancy poses particular problem with increased risk of perinatal transmission of hepatitis B virus to children. Treatment can also be problem, and several nucleoside analogues have dual antiviral activity and associated with emergence of drug reaction. Hepatitis delta virus, it is RNA defective virus that has no independent existence, and it requires hepatitis B virus for replication and has some source and modes of spread. Spread is by blood, saliva, sexual and vertical. Chronic infection, yes, by the presence of the hepatitis B virus, and prevention by prevented by the hepatitis B vaccination. Geographical distribution is seen. It is worldwide distribution, endemic in parts of Mediterranean basin, Africa and South America. In non-endemic areas, transmission is mainly by parenteral drug misuse. It can infect simultaneously with hepatitis B virus and can superinfect those who are already chronic carrier of hepatitis B virus. Simultaneous infection gives rise to acute hepatitis, often severe, but is limited by recovery from hepatitis B virus infection. Individuals with chronic carrier of hepatitis B virus cause acute hepatitis with spontaneous recovery and occasionally simultaneous cessation of the chronic hepatitis B virus infection. Chronic infection with hepatitis B virus and hepatitis D virus can also occur, and this frequently causes the rapidly progressive chronic hepatitis and eventually cirrhosis. Investigations shows that hepatitis D virus has a single antigen to which the infected person make antibody anti-HDV, and delta antigen appears in the blood only transitorily, and in practice diagnosis depend upon detecting the anti-hepatitis D virus antibody. Simultaneous infection with hepatitis B and D followed by full recovery is associated with the appearance of low titer of anti-hepatitis D virus of IgM type within few days of onset of illness, and antibody generally disappear within 2 months but persist in few patients, as you see in the upper graph. Superinfection of hepatitis B virus infection patients leads to production of high titer of anti-HDV, initially IgM and later IgG. Such patients have anti-HD virus titer at high level, as shown in the lower graph. Effective management of the hepatitis B prevents hepatitis D.